Hello again and welcome. My name is Dr. Lennox Hoyt. I'm a fellowship trained urogynecologist and pelvic surgeon. I have hold a Doctor of Medicine degree from Stanford University in Palo Alto, California, and residency training in OBGYN from Brigham and Women's/Mass General Hospital in the Harvard system in Boston. I'm also a fellowship trained urogynecologist and pelvic reconstructive surgeon, and I trained at Loyola University System in Chicago area. Today, I'd like to talk to you about mesh. Surgical mesh has been used traditionally to treat problems of hernias in places where using your own tissue for the repair is considered insufficient or inadequate. So, for example, in hernias and different types, incisional hernias, inguinal hernias, umbilical hernias, mesh has traditionally been used for that purpose. Sometime along the way, the idea of using mesh to treat pelvic organ prolapse came along. Somewhere in the late 60s, early 70s, it was pioneered in the United States at Duke University, where they used specially prepared Marlex synthetic mesh placed transabdominally, as in through the incisions in the abdomen, in order to repair prolapse. Those procedures turned out to be quite successful, but they were very complicated to perform and required a great deal of surgical expertise and skill. They had their own sets of complications. Over time, those meshes that were used for abdominally placed surgeries got lighter, less weight to them, the pore sizes increases, they became more friendly to use, so that by the late 90s, early 2000s, the meshes were lightweight enough so that when you placed them abdominally, they tended to have low complication rates with high rates of success, still with noticeable side effects, including risk of high blood loss and complications of surgery related to bowel and bladder injuries. Over time, those surgeries using laparoscopic techniques and later on robotic techniques to make the surgeries be much more straightforward, minimally invasive, and also quite effective with relatively low complication rates that balance the risks against the benefits of the procedure. During some time in the period of the late 1990s to early 2000s, the idea of using synthetic mesh, polypropylene specifically, placed through the vagina to repair prolapse, that technique was pioneered and brought forward and advertised as a cure. So that is, the mesh is placed through the vagina using a vaginal incisions through an environment that is essentially cannot be permanently sterilized. And the mesh was also anchored in ways that distorted the anatomy of the vagina in exchange for a more straightforward, quote, faster and easier procedure. It turns out that transvaginally placed mesh developed their own sets of complications, primarily based on how the mesh was placed and anchored. So in the abdominal space, mesh is anchored vertically. It is designed to pull the vagina back up into place normally. When it's placed through the vagina, usually it's designed to work by anchoring the vagina laterally. So it pulls the vagina from side to side, and it turns out many times the tissues that the mesh is anchored into in order to hold it in place, those tissues tend to be muscles and ligaments. And quite frankly, as the mesh healed, the scar itself would shrink, pulling on the mesh and causing pain. In my practice, the most common symptoms that I've seen from transvaginal mesh complications, number one, are mesh erosion, pain with intercourse, pain at rest in the vagina, difficult bowel emptying, pain with attempts at bowel movement. And I think the fourth one would be difficulty emptying the bladder, sometimes alternating with urinary incontinence. So mesh complications are real. The ones that we did not talk about, also that would be included in the top four, if you will, I know it's more than four, but is mesh erosion. And that happens when the mesh that's implanted in the vagina actually peeks through the vaginal tissues and literally exposes itself into the vagina, causing things like bleeding and sometimes pain of your partner with intercourse during penetration, and a whole host of other problems, foul vaginal discharge, and some other things that are quite unpleasant. So mesh complications can be quite unpleasant when they occur, and we do know that the rate of mesh complications are higher when the mesh for prolapse repair is placed transvaginally. So we understand that. Let's suppose you had a mesh surgery, or any surgery for that matter, but let's concentrate today on mesh surgery for prolapse repair. If you've had that surgery and you find that after that surgery you develop symptoms that you didn't have before, specifically symptoms of pelvic pain, vaginal bleeding, pain with intercourse, difficult bowel movements, difficulty emptying your bladder, or worsened urinary or stool incontinence, if you develop those symptoms and they occurred or started after the mesh was placed, and you're clear that they didn't exist before, if you really think that something's wrong as a result of your mesh surgery, it's important to have that evaluated. Feel like your mesh is causing you pain? You're probably right, especially if that pain started de novo or after you had your surgery. So find a fellowship trained urogynecologist with a lot of experience in mesh explantation or removal of mesh or treating surgical complications. That's the way to go if you really would like a good, thorough evaluation and treatment of these new onset problems that may be related to your transvaginal mesh placement. I want to emphasize that abdominally placed mesh for prolapse repair. The name of the procedure is called an abdominal sacrocolpopexy. It can be done by an open incision or robotically, laparoscopically. I'm not talking about mesh complications related to abdominal mesh placement. They tend to be rare. That abdominal mesh placement for prolapse repair is considered a gold standard. If you have these complications, the best person to see is a fellowship trained urogynecologist with extensive surgical experience in treating mesh complications. Why did the mesh cause this problem? I don't think anyone is in a position to really answer that. I think it's a case-by-case situation to try and understand what particular problem the patient has and to design a way to fix the problem so that the patient's not experiencing those symptoms.